Good morning, everyone, and welcome to the WFH Practical Education on Bleeding Disorders Knowledge for All webinar series. This is the second for this year and the last. We're pleased to have a nice cadre of speakers for us to give some talks on current states in bleeding disorders, care, and treatment. For the first hour, we'll have 3 speakers, and then that'll be followed by 3 speakers in the second hour. The talks are going to be wide-ranging on a variety of current issues in bleeding disorders care and treatment. Some of us are just coming back from the American Society of Hematology meeting in New Orleans, where there was not a lot, but some new information on hemophilia. A lot of it was focused on treatments, and we'll be hearing a little bit more about that in the second hour. So with that, I'd like to introduce the first 3 speakers for our first hour. Our first speaker is Patricia Cabre, and she's a pediatrician and program and service coordinator at the Catalan Association of Hemophilia in Barcelona, Spain. And she's also a member of the WFH Psychosocial Committee. Our second speaker is Adolfo Linnaeus. He's the corporate chief medical officer at the Fundación Santa Fe de Bogotá and a staff member of the Department of Orthopedics and Traumatology and a clinical professor at the Universidad de los Andes Medical School in Colombia. And then our third speaker is Luigi Solomeno. He's the director of emergency trauma and trauma department and rare disease service at the IRCCS Ca Grande Foundation, Maggiore Hospital in Milan, Italy. He's also been the lead organizer for the WFH 10th International Musculoskeletal Congress in 2007. With that, I would like to turn it over to Patricia.
Good morning, good afternoon, or good evening. My name is Patricia Cabre, and I am the Program and Service Coordinator of the Catalan Association of Hemophilia. We are located in Barcelona, and we are attending more or less 400 persons with bleeding disorders. These are my disclosures. I have been asked to speak today about resilience and mindfulness. Probably these words sound familiar to you, because there is a lot of scientific literature about them. I would like to thank the World Federation of Hemophilia for including psychosocial topics in today's session, because many times they are the forgotten ones. In a chronic disease such as hemophilia, treatments always come first. But above all, we must always remember that behind a person with a disease, there is a human being who needs not only medical assistance, but many other things. So it was fundamental to take care of the person, not only his hemophilia. Hemophilia is not only an organic affection, but also the subjective effects that it produces in each person or family member. So starting this session in that way is important because it implies a firm commitment to attend in a comprehensive way all the aspects related to bleeding disorders. The dictionary defines resilience as the power or ability to return to the original form position after being bent, compressed, or stretched. It's like elasticity. Applying the word more to people, it means the ability of a person to adjust or recover rapidly from illness, adversity, major life changes, buoyancy. The American Psychological Association defines resilience as the process of adapting well in the face of adversity, trauma, tragedy, threats, or even significant sources of stress. This concept emerged from positive psychology movement. It started in 1998, and it's a field more focused on the positive view about what are the patient's strengths, their abilities, their successes, where are they good at. Resilience is a way of life that everyone can achieve regardless of their situation. But the research about it is not conclusive. Is it a personality trait, a process, an outcome? There is no consensus, but whatever it is, individuals can develop resilience, and it is a positive attribute, a desirable goal. Some studies identify 4 factors that help developing resilience. First, a strong intellectual function, having a close relationship with a caring parent, having bonds with caring adults outside the family, and having moderate difficulties in early life. The first 3 are positive things, the last sounds negative, and it is. But when you think about it, getting through difficult times is really what builds resilience. Usually, most people with hemophilia have experienced at least moderate difficulties, maybe even severe ones, in their early lives and after. One hypothesis is that perhaps it made them more resilient. In fact, the study Perceived Well-Being and Mental Health in Hemophilia, published in the journal Psychology, Health and Medicine, found that people with chronic diseases like hemophilia are not only able to handle daily challenges, but also to thrive and grow through hardship better than adults without a chronic condition. When going through a challenging time, the good news is that there are lots of ways you can help yourself to feel better, even though we all deal with things differently. For this reason, as professionals, we need to attend each person from his or her singularity, because there is no one hemophilia. Hemophilia is everyone's, not two are alike. There are some assessment tools to evaluate patients' ability to be resilient. Here you can see 2 formal inventories, Connor-Davidson Resilience Scale and a scale of Protective Factors 24. We can use that, but we can assess resilience informally too. We attend patients, and it's precisely during our conversations that we can hear what is important to them and how they manage the situations. Listen for evidence of their strengths, their interests, their hopes. You can recall patients' and family reaction to bleeding disorder diagnosis, or how they have responded to bleeding events. Even notice how they have responded to other challenges. With all this background, we can help patients to be resilient. For example, in our sessions, we can just reminding them of their own successful strategies in previous stressful situations. We can offer to be a sounding board for patients' ideas about responding to new problems, and of course we can encourage them to build particular solutions that they feel comfortable with to face their challenges. Finally, I give you a reference of a development of a resilience intervention focused specifically on promoting resilience among individuals with disabilities. As we saw before, having support outside oneself is a crucial piece of resilience. Sure, in your country there is one hemophilia organization that supports the bleeding disorders community. In general, they have patient and family attention programs and up-to-date information. They offer peer mentoring or group learning opportunities and usually celebrate an annual meeting or conference. In fact, they provide a lot of resources. But you can have more information and support through all hemophilia treatment centers because they have a multidisciplinary team to attend globally their patients. Or you can look at the website of the World Federation of Hemophilia or participate in educational programs like this one. And there are many bleeding disorders websites that you can consult, but be sure they are a serious source of information. So that is our community. all of us, we are really involved and committed in improving the quality of life of people with bleeding disorders. Now, I would like to share with you the words of one patient of our association. You can find his testimony in the book that we published to celebrate our 40th anniversary. He explains, "If you will allow me, I will make an allegory here. Throughout my childhood and adolescence, I had always looked at life in the same way as a young fisherman looks at the sea, like a wonderful and immense source of fish, a food source of infinite textures and colors, always surprising but always beautiful, always precious. But one day, this innocent fisherman has a son and goes fishing with him. This son is pushed by a wave, falls into the sea, and is not recovered alive. As you can imagine, the idea that the fisherman has of the sea changes radically. This benevolent body of water, supplier of jewels and food, goes from being a bright place full of opportunities to become the darkest and worst of nightmares. Well, the same thing happened to me in life. From being a promise of the future opportunities and prosperity, existence turned into an inhospitable, treacherous, and dark place, the worst of nightmares. But over time, if you survive, that view changes again, and you learn that neither the sea is a swimming pool nor life a Hollywood movie. Not everything is white, not everything is black. Everyone must learn to accept the gains and losses that our existence entails. And when you come to this conclusion, you start enjoying the gifts that life offers you again. Now my present is fine and the future is unpredictable. My wish is that there is more love. I always say that my experience has taught me that without health, happiness is possible, but without love, it is impossible. For me, this is the better example to explain what resilience is. Now, I will try to summarize what mindfulness is. As I said before, mindfulness and resilience are very popular. Both have become buzzwords in the social science and mental health fields. There are many studies that explore the potential of mindfulness in different areas, and precisely some of them suggest that this technique helps to develop resilience. Mindfulness stems from Buddhism and specifically from Vipassana meditation. Vipassana means seeing things as they are, and this is the goal of this type of meditation. According to the dictionary, mindfulness is a technique in which one focuses one's full attention only on the present, experiencing thoughts, feelings, and sensations, but not judging them. Now I'll try to explain a short practice to get you started. First, find a place that feels calm and quiet to you. If you're just starting, choose a short time, such as 5 or 10 minutes. Position oneself comfortably. Just make sure you are stable and in a position you can stay in for a while. Feel your breath. Take slow, deep breaths. Follow the sensation of your breath as it goes out and as it goes in. Feel the stomach move in and out with each breath. Sure, your attention will wander to other places. When you notice this, simply return your attention to the breath. Don't judge yourself or obsess over the content of the thoughts you find yourself lost in. Just come back. It's all about returning your attention again and again to the present moment, to the breath. We use the sensation of the breath as an anchor to the present moment. When we practice mindfulness, we are practicing the art of creating a space for ourselves, space to think, space to breathe, space between ourselves and our reactions. While mindfulness might seem simple, it's not necessarily all that easy. The real challenge is to make time every day to just keep doing it. The research on mindfulness and its multiple benefits is huge. I only summarize some of them. Mindfulness allows you to train attention regulation and allows to be aware of what we tend to overlook when we activate autopilot. Mindfulness allows you to be aware of what you are feeling right now. With this, we can suffer less from emotions felt in the past, anticipate less the emotions that might arise in the future, and also be more aware of what emotions we are feeling in the present. Anxiety is a normal and functional emotion, which serves to activate the body in front of a possible danger. However, sometimes it becomes pathological. Anxiety is born from a strong concern for the future, from an anticipatory fear. For this reason, mindfulness helps reduce anxiety by focusing attention on the present moment. And finally, there are several studies that demonstrate that mindfulness helps pain management. In fact, in the third edition World Federation of Hemophilia guidelines for the management of hemophilia, there is a specific recommendation for people with chronic arthropathy. I would like to end by highlighting two ideas that appear in these guidelines. First, psychosocial intervention strengthens patient resilience by fostering self and health efficacy, cognitive flexibility, hardiness, optimism, and self-advocacy. And second, peer mentoring and group learning opportunities help foster support, reduce isolation, enhance receptivity to information, and strengthen resilience. Services as programs like these are often offered by the association. So, precisely from my experience in a patient association, I encourage you to contact and take advantage of all that services. Thank you for your attention, and in these days I would wish you a Merry Christmas with a picture of the typical Catalan Christmas tradition, el tío.
Well, thank you very much, Patricia. That was really a very nice comment on mindfulness that is of benefit to all of us. We are next moving on to a discussion on stubborn joints with Adolfo Linnaeus. Adolfo?
Thank you, Glenn. It'll just take a second for me here to share my slides, which I need our previous speaker to release the screen for me, please.
Okay, and let me, while we're waiting, let me say we'll do questions and answers at the end of each hour. So please put your questions into the question and answer box on your screen.
Adolfo, you should have control now.
I get a message that says that the previous speaker has not released the control. It went green and then yellow again. So do whatever you did once again, please. There. No.
I can see your slides.
Can you?
That's also, if you're moving the mouse, you can try going to the bottom left corner of the screen, and you should be able to click through the arrows.
Wonderful. If Glenn can see the slides, then we should be okay. Are we? Am I okay?
Yeah, looks good.
Wonderful. Thank you very much. This is a stubborn screen, which is a wonderful way of starting this conversation about stubborn joint bleeds and joint arthropathy. The purpose with this conversation, and is to present the pathological repercussions of repetitive bleeding in persons with hemophilia, and discuss the therapeutic solutions to the hemophilic arthropathy. The essence of the conversation would be in reference to that moment when things are not really working well for the joint. So I've divided the conversation in 6 brief points, and we'll start with the acute bleed. And we all know what an acute bleed looks like. And the question is, when you get that feeling that acute bleed is not responding to treatment as it should, what I do and what I suggest you consider is these 5 questions in that sequence. The first question is the diagnosis of the coagulopathy really correct? And I think this question begs being asked many times throughout the life of the patient. Second question is, has the patient developed an indetectable inhibitor? The third, which is sort of a psychological trap, and that is, once you have a diagnosis of a coagulopathy, you have a tendency to stick to it. And the question is there an associated coagulopathy, a second coagulopathy which is associated, which is not infrequent? The fourth, don't forget the liver. Is the liver really functional? Can the problem be the liver itself and not the diagnosis of the original coagulopathy? And finally, back to orthopedics or rehab, is there an external mechanical factor that is affecting that joint? So the point here is those 5 questions will get you out of trouble many times because there may be mistakes in one of those 5 dimensions. If we're now facing a patient that has synovitis, that joint that doesn't go back to normal between bleeds, I would like to invite you to consider that synovitis may result from 3 different clinical situations. The first are patients that are on primary prophylaxis and develop synovitis. The second are patients that are without prophylaxis and are not responding to treatment with secondary prophylaxis. And the third is patients who are now in a state of synovitis, but were in the absence of primary or secondary prophylaxis. And the reason why these 3 groups of patients should be divided is because the prognosis is different, and the way you approach the problems are different. And these 3 types of patients are often combined in the literature that reports treatment about synovitis. So sometimes you get a lot of spread, heterogeneous results, and perhaps part of that heterogeneity is explained by these 3 different groups of patients that are typically and erroneously, I think, grouped in a single pack. The output of these situation, what we want to achieve is to deactivate the synovium. There's an abundance of literature that shows that active synovium is severely destructive to the joint, and we want to get back the complete range of motion, muscle strength, and joint speed. And I underscore the word complete. It is frequent that we aim for suboptimal results and that you give up during the process. And I think we have enough resources today to address this to the fullest and don't compromise in achieving optimal results as you would in a patient without hemophilia. So we want to return the patient to a state where prophylaxis be effective in preventing articular bleeds or subclinical synovitis. Now, since I was asked to address primarily environments of developing economies, which like is the case in Colombia where I live, I want to underscore that open synovectomy is something we essentially don't do unless we have to open a joint for any additional reason. But it was a popular procedure in the past. It's currently used for other conditions such as arthritis in some countries in the world, but we typically don't recommend this approach. It is consuming in terms of resources dedicated to coagulation and rehabilitation, and typically you can only achieve suboptimal resection of the synovium. So if the program has a surgical inclination primarily, arthroscopic synovectomy will provide resolution of chronic synovectomy in about 80% of the cases or more with a single intervention. The same is true for radio synoviothesis, which is a procedure that has been used for many years and for many reasons around the world. The logistics are complex in terms of the availability of the isotope. But if you do have access to isotopes that are appropriate for this procedure, this would be my procedure of choice for the treatment of synovitis. And this is the case also for WFH in its recently published guideline. There's a variety of isotopes, and they have they all have indications in terms of the size of the joint or the speed of delivery of the energy, of the radioactive energy, or the size of the particle. And there are different arguments to choose one over the other, but essentially most of them work very well. And there's a summary of what we think about this published in their documents that are available through the World Federation of Hemophilia website, which was published many years ago with Dr. Silva and Locke from Los Angeles. And the position has not really changed with this procedure, so this document remains current. I underscore here that chemical synovectomy is usually off-the-label use of these medications. They were not designed for this purpose. However, there's a lot of experience with this procedure. Dr. Solimeno, who is going to be lecturing after me, has published on this subject, as have many others around the world. And despite the fact that it is off the label, it is a procedure that works very well. If you're curious about this and you're thinking about using oxytetracycline, I recommend this paper by Roberto Bernal in Hemophilia, which will teach you step by step how it is done. We do it in our hospital in Colombia. We have permission from our ethics committee and from our pharmacological committee, and we have a very clear, informed consent when we do this in patients. But I want to remind you that it is off-the-label use for these medications. Now, the problem is that if even sometimes after getting control of the synovitis, there are flexion contractures in elbows and knees and ankles, and they're very difficult to handle. There are many tricks from the old books of orthopedics and rehab. This is one that we've used successfully for many years, and it's the use of a desubluxation and extension hinge. We can also use casts and wedges, and there's a lot of experience in emerging economies with these procedures. This is a boy, as you can see, hanging from the parallel bars, who has a flexion contracture of both knees, but he doesn't have synovitis anymore. And here are two examples of patients that are undergoing the procedure, which gives them a lot of control in terms of the speed at which they extend the knees, and a lot of comfort in terms of the ability to move back and forth as they progress at their own leisure. Typically, within 2 or 3 weeks, you get full extension, unless there's a mechanical restriction, which was the case for this young boy, who is now lying prone under anesthesia. And you can see the residual flexion contracture after having performed synovectomy and after having done casts and wedges and extension hinges. We still have too much flexion that impedes his gait. So for these patients, we bring procedures that have been long used in pediatric orthopedic surgery. In this case, a posterior release of the popliteal fossa, which is a procedure that can be done through a central incision or two lateral incisions, and essentially will provide extension that can be secured via cast, and then, of course, with the enormous help of rehabilitation. Now, sometimes there are external factors, and there are a few that you have to watch out for. This is a classical contracture of the gastrocnemius, a muscle following a muscular bleed that brings the ankle into plantar flexion and subtalar joint in inversion. And unless you work on the upper part of this segment, you wouldn't be able to correct the equinus and the inversion. This is quite obvious, but sometimes things are not so obvious. And I think the favorite suspect in the subclinical external conditions that make things difficult to handle is the psoas iliacus bleeds. Sometimes they are not easy to spot. You can see here on these CT scan the large bleed on the left psoas iliacus highlighted in pink. And patients essentially undergo severe compression of the femoral nerve, and they lose control of the quadriceps and some sensation in the anterior portion of the thigh and knee. And the problem is that these patients develop atrophy of the quadriceps, and they lose power of extension, and the knee becomes unstable. And then you get synovitis of the knee, and you start working on the knee, and it won't improve unless the strength of the quadriceps improves and the compression of the nerve resolves. So these are situations where the knee really calls your attention, and you can neglect to look higher up and realize that there is a problem that is actually primary, and the knee is secondary as a consequence of the former. This is a classical situation. Some patients move into severe ankylosis, and even with posterior releases, you don't get enough extension. And just a few degrees of flexure contracture will have an enormous impact on the quality of gait of these patients. And as treatments have progressed, the intolerance to imperfection has increased in persons with hemophilia, which I think is a very good thing. But we need to perform up to par to keep patients satisfied, independent, mobile, and healthy. And the same is true for their parents. So in this case, we perform osteotomies. You can see here a supracondylar osteotomy, which is fixed by two pins, sometimes percutaneous screws. And you can get the leg to extension, having undergone first physiotherapy and synovectomy, then cast wedges, then posterior release, and now a supracondylar osteotomy as the child gets older and the skeleton is more mature. You may need to gain those 15 or 20 degrees of extension via a surgical osteotomy. The target always being getting that full extension, which is our primary objective. And sometimes the situation is irrecuperable, and of course, reconstructive surgery is available. And there are a number of technical tidbits and knowledge that is required, and especially a lot of interaction in harmony with the musculoskeletal multidisciplinary team to achieve good results. But large centers around the world have demonstrated again and again that this is possible, and when all fails, reconstructive surgery is a very good option. One final word of caution, and it is the tendency of persons with hemophilia to develop arthrofibrosis. There's literature now to indicate that the healing is abnormal in persons with hemophilia. And this is probably part of the explanation why you see arthrofibrosis, rigidity in the joints after surgery with greater frequency, and which is hard to handle and requires, once again, an experienced team. So you may be surprised by this, but the literature actually indicates that it is more frequent. So I hope, Glenn, to have addressed with this 6 points certain elements that characterize joints that are behaving in a stubborn manner. And this colorful slide essentially shows that there's a route that goes from the acute bleed to secondary arthrosis, and the earlier you intervene, the better the final results with these young boys. So once again, thank you very much, Glenn, for the opportunity to discuss this subject, and I look forward to your challenging questions.
Well, thank you very much, Adolfo. And I always learn something when I listen to you. We are fortunate to have a second internationally known orthopedist presenting to us this morning, today, and that is Luigi Salamino. Luigi is going to be speaking on exercise and aging. Luigi?
Thank you, Glenn. First of all, I want to thank you and the organizer for involving me in this so important faculty. Good afternoon, or good morning, or good night. I don't know where you are in the world. And I had to speak about aging and exercise. And I'm trying to move my... No. I'm trying to move my presentation. I don't know how I can go on. Oh, okay. This is the outline of my presentation. That, as you know, I will speak about problems in elderly hemophilia patients, something about surgery, and after one session related to exercise and rehabilitation. So I would like to share my presentation with Valentina Begnazzi. It is the physio of the Hemophilia Center in our hospital in Milan. So this slide is just to understand for you what hemophilia is. Hemophilia is, for all of you, is a clotting disease with orthopedic complication. In my mind, after many years, is an orthopedic disease with bleeding complication. This is related to the clinical of the hemophilia, and it leads to hemophilic arthropathy. And now today, something new, but is also a new challenge because we start to have elderly hemophilia patient. So aging is a beautiful challenge, and that has been possible for the improvement, for the progresses of replacement therapy, probably from the antiviral drugs for sure. But generally, I say that probably the global comprehensive care provided by the Hemophilia Center today are improved and giving a longer life. So there is a problem for the treaters, but now they have to treat problems that probably we never observed before in this population. And so the difficult now is to treat in one side hemophilia problems, in the other side age-related problems, and that are the same but in general population. And most of the time, elderly hemophilia patients have hepatitis C or hepatitis B, HIV positive, and this leads to a cirrhosis in 20 years in about 30%. And for the surgeon, this could be a problem in doing surgery. Obviously, they can have also coexisting disease in the heart and the kidneys or what else. For sure, they need intensive rehab program, and there is an improved access to orthopedic treatment. But from surgical point of view, cardiovascular disease can really be a problem due to the opposing risk in one side of bleeding from hemophilia and antithromboembolic treatment and risk of thrombosis. So this could be a challenge for the team, for the anesthesiologist overall, and for the surgery, for the surgeon, obviously. And about guidelines, yes, at the moment, I think that data about elderly patients with hemophilia remain limited. We cannot say that there are really dedicated guidelines, so the treatment of the disease are the same that people without hemophilia. But also for the World Federation, I think there are some guidelines that they say that they need a comprehensive treatment, they need a multidisciplinary approach. For the musculoskeletal problems, we can have, in any cases, a conservative options or surgical options. Most of the time, the pain control is a particular change in elderly patients related to the contraindication of the use of many effective analgesics. So we have seen before by Patricia that mindfulness can help us also to manage pain. And how to manage bleeding disorders. So they could be elective, they could be also emergency. So for example, we had some fractures of the femur in elderly hemophilia patients. And overall, the perioperative hemostatic management, you have to pay attention. You need an individualized approach to evaluate every risk of bleeding in both sides. And so, for this reason, you need a multidisciplinary approach is mandatory. And it could be interesting to evaluate this data collected in Norway, just to see that there was an increase of surgery in the patient between 1997 to 2014. And the interpretation was with increased life expectancy, they were saying a growing need for treatment of disease not related to hemophilia. And as I told you before, you need a multidisciplinary team. The team is made by, in any countries, probably by a hematologist, by a surgeon, or by a physiotherapist. But what we need now is something more. We need a geriatrician, we need cardiologists, we need occupational therapists, and else. And as I told you before, World Federation gave some guideline, but the focus is on comprehensive care team. And in my opinion, also infectivologists have to be involved related to surgery in elderly patients, because we have to evaluate our patient a lot before to do surgery. And in prevention obviously is crucial. From the orthopedic point of view, you have to monitor the target joints for, as in young hemophilia patient, you can use an X-ray. Probably ultrasounds in elderly patients is not so important like in kids or young hemophilia patient. And most of the time we need also CT scan or MRI to evaluate the defect of the bone. So now we will enter in with the physiotherapy point of view. So I give the talk to Valentina.
Yeah. So from a physiotherapeutic point of view, when we evaluate a patient, especially an elder patient, we have to consider the whole body. And we have to start from a postural analysis. At the same time, to evaluate the patient, we have to perform a baropodometric and a stabilometric barefoot. And we can use some questionnaires like HJHS or quality of life questionnaires to evaluate the perception of the pain and of the functionality from the point of view of the patient. We also usually test flexibility, which is a very important skill to guarantee a good ability to move. All these evaluations together lead to the sport choice, which is fundamental in any kind of patient. So how can we encourage physical activity in these patients? We all know that during the 70s, people with hemophilia were precluded to do any kind of physical activity due to a perceived increased risk of bleeding. Nowadays, the guidelines from World Federation and from World Federation indicates physical activity as essential for health maintenance. but still is not emphasized enough, and many people with hemophilia have low to no physical activities. For each patient, we have to find an individual-based behavior change approach, both from a physiotherapeutic point of view and from a psychological point of view. As I told you before, postural analysis is the base for our evaluation. We have to figure which is the relations between structure and function. We have to focus on the whole body, which is an indivisible system. As Professor Linas told you before, we can have stubborn joint in our body, but that stubborn joint won't affect just that part of the body. A problematic ankle could result in an issue in the back, for example. These are called dysfunctions and have to be addressed when we evaluate a patient. As I was telling you, this is an example of what postural analysis can show. This patient is supposed to be fine. I mean, he doesn't need any kind of surgery, but when we evaluate him, we see that he's compensating his issues in the ankles. He's got a fixed elbow, and this leads, of course, to an imbalance in the whole body. When we talk about prevention, treatment are basically exercises. Exercises need to be addressed to train strength and resistance, but also by means of proprioception and stretching. All these exercises can maintain or even improve global motor function, pulmonary function, and cardiovascular function. The goal of this kind of treatment is to prevent and control as much as possible the problems peculiar of any person, especially in the elderly. So, strength exercises can start from isometric exercises to increase strength, but if the person can tolerate it, we can also do isotonic exercise, and we can use gravity and body weight for additional training. The strengthening of muscles is fundamental to stabilize joints affected by chronic arthropathy. And the resistance training is also important to improve walking ability. Also, global proprioception is fundamental to reduce the risk of falls and the kinesiophobia in this population. It also can help to avoid the vicious cycle of sedentary lifestyle that can worsen the musculoskeletal condition and increase the risk of bleeding. The main exercise that we have to guarantee our patients are the stretching exercise, because stretching can help us to decrease pain and improve balance, and at the same time can help us compensate the shortening caused by dysfunction, the one that we observed during the postural analysis checkup. Once we've got our plan for any specific patient, any individualized patient, we can decide the sport with these people, with any person. As you know, PA can improve treatment efficacy, but how can we choose a sport? Of course, we have to take into consideration the individual preferences and its interests, the physical condition and disability, but also the local context and the available resources. The guideline encourage basically non-contact sports, but also high contact and collision sport can be considered if the individual is on an adequate prophylaxis to cover such activities. When we talk about sport, we don't have to talk about high intensity sport. Even Nordic walking can be a useful activity for elderly patients, and also swimming. So the take-home message is that aging and hemophilia is really a new beautiful challenge that has to be addressed by a multidisciplinary team that take into consideration a comprehensive care. This approach has to be mandatory in order to address any kind of issues that elderly can present. But at this moment, we still don't have enough data to have a proper guideline. So more studies has to be done in order to understand how to treat these patients properly. Thank you very much.
Thank you, Valentina. Thank you, Glenn. Thank you to everybody.
Well, thank you, Luigi and Valentina, for that nice presentation. So we're now going to open it up for some questions. And some questions have come in through our Q&A. So let me start with Patricia. Make sure Patricia is on. Yes.
We need help activating the videos, Glenn.
Yes, yes, of course, I am here.
Okay. And so Evelyn and Julia, can you activate the videos? There we go. Okay, so Patricia, a question came in that Julia has gotten translated. It's a person from Mali, and he's interested in resilience and what approach should the patient association take toward parents whose child has been diagnosed with hemophilia? So it's consistent with another question about how resilience might be used in children.
Okay, I try to both. Sorry, I have to mute the translator, or sorry. Okay, a moment.
You have the translator in the background?
If you're listening to the interpreter, you can just go to the interpreter. Yeah.
No, sorry. Yes. The first question, no? I think that financial difficulties are always a problem and a challenge. But from a patient association, and especially for families with small children, I think the most important thing is to help them not to feel alone. Schedule activities that allow the change of experiences, that allow mutual knowledge. For example, all groups of parents are a great resource for promoting resilience because many families help each other. And as a professionals, always value how they have situations around life. And the second question, no, that if young children can practice mindfulness. I think yes, but you have to adapt the practice to the age of every kid, no? But once I read an article that expressed that learning mindfulness is not like piano sessions, because where you can have someone else teach it to your children, in the sense that you are your parent. So first, you have to learn to practice it. And after, when you have experience with this practice and you can see how it works with you, then you can do with your kids. But of course, is a nice activity to do with children.
Okay, thank you, Patricia. A question for Luigi. A question for Adolfo first. Would you expect factor VIII prophylaxis as the standard of care in hemophilia A to prevent progressive joint damage in the near future? And what role might extended half-life factors have?
I think that any tool that decreases the fluctuation of the trough level of factor is aligned very, very coherently with joint preservation. Finding that trough level is the challenge. But once you do, if you have the resources to maintain that patient or that person above that trough level, I think that's the way to go. Now, once you do that, if you can achieve it with longer acting agents, It has a direct impact on quality of life, in mobility, and independence. And I think anybody who's working in hemophilia today should have those 3 words sort of in a bulletin board in front of wherever they sit, because when you look at surveys where patients or persons or caregivers were able to express their needs and their expectations about the future of care of hemophilia, those are the 3 words that are very congruent, Glenn. And I submit to you that despite the location of the world where you ask the question, you get a very similar answer. We used to think that this was an aspiration of developed economies, but interestingly, that's not the case. So maintaining the patient above the trough level and extending or separating the discomfort of the patient, one as far from the other as good as possible, be it a month, a year, I mean, as far as you can, that would be certainly welcome anywhere in the world.
Okay, thank you. And then I'm going to ask both Luigi and Adolfo to comment on this one. How young a patient would be considered for total knee replacement? Luigi, do you want to go first?
Yes. There is no limit in my mind. I had to discuss because last year I did a knee replacement in a guy of 14 years old. So it was very dramatic situation, obviously. Inhibitor patients on a chair. In one side, I was able to do the extension of because he had a 90 degrees of flexion contractor. In one side, I was able to extend the knee. The other one was not. The joint was completely dramatic, destroyed. And so at the end, I decided to do a joint replacement, a knee replacement. And so in any cases, when we do joint knee replacement, overall in hemophilic patient, we are speaking about young person. For sure, in kids is only sometimes, but I had these cases. So for me, no limits.
Okay.
When we need request.
Adolfo, anything to add?
Not in the opposition, but rather to strengthen Luigi's position. We have experienced, both Luigi and I, in joint replacements in teenagers for other conditions like idiopathic protrusio in young women, 12 years old, or Marfan syndrome, typically in men who have joint problems very early on. And the critical point, Glenn, is when the person has reached that point where, in order to move forward with his aspirations, the joint is an impediment. Here, a lot of help is needed from the mental health colleagues, trying to assess the level of maturity and the legitimacy of the request from the point of view of whether this person is mature enough to really make the decision to use that segment of life where he will have a functional joint, understanding there will be problems in the future, or if it is a tantrum from an adolescent who is having trouble with life. So that's the challenge, and I'm sure Luigi will agree with this. So we spend a lot of time talking with this patient and his family, and sometimes they come across with a very strong message, with a very mature position, with a very strong necessity to progress in his personal and work life, and then we're perfectly fine with that decision. When you have a child or an adolescent who's having trouble with his skin, with his hair, with his life, with everything, that's when you really have to stop and try to postpone that decision.
Okay,
I hope this makes sense.
Yes. So we have a couple more questions, so we need some short answers. I think this is for Valentina, and the question is some easy instructions to give adults with hemophilia, to start some strengthening without any extra home equipment.
Okay, so of course, any person should go under an evaluation before to see what should be done with that person. You know, it's an individualized program, it's not that easy. But I'd say that the body weight is quite enough to start with a rehabilitation program and any kind of exercise, I would start with isometric contraction, which are easier to do, and also with stretching as well. We cannot forget with stretching. We cannot forget of stretching. Starting from that, we get the muscles ready to be strengthened with isometric exercises. I'd say this is the starting point.
Okay. All right. Well, thank you. Let me take one last question. So I need a short answer. This is from my old friend Shrivan Ravenbach. So Adolfo, do you consider synovectomies in children with inhibitors before they complete their growth? So
Absolutely.
Young children with inhibitors.
Absolutely, yes.
Okay, thank you. All right, we're going to need to move on. We have a few more questions. If I could ask Luigi and Adolfo to go into the chat or go into the Q&A and see if you might be able to answer a couple of these, that would be terrific. Our next hour is going to be 3 more speakers. I'll introduce all of them, and then we'll move into the presentations, and then we'll do Q&A at the end of that. So our first speaker is Radek Kazmarek. He's a postdoctoral research associate at the Gene and Cell Therapy Group at the Wells Center for Pediatric Research at Indiana University. And he's also been working with me closely over the last few years as the chair of the WFH Coagulation Products Safety, Supply, and Access Committee, which has been very active. He'll be speaking about therapeutic products. And then our next speaker is Catherine Hayward, who's a professor of pathology and molecular medicine at McMaster University in Ontario, Canada. And her research focuses on the molecular aspects of hemostasis and platelet function, and she will be talking about platelets. And then our third speaker is Dr. Andy James. She's a professor of obstetrics and gynecology in the Division of Maternal and Fetal Medicine and a consulting professor of medicine in the Division of Hematology at Duke University in North Carolina, United States. And her practice, research, and publications over many years pertain to reproductive issues among women with bleeding disorders. So we'll move on to Radek. It's yours, Radek.
Thank you, Glenn. Let me just check if I have control of the screen yet. Perfect, I do. Okay. Hello, everyone. I'm going to give you a brief but broad overview of the current treatment landscape. There's a lot to talk about. I've got just 15 minutes, so let's get right to it. The hemophilia treatment armamentarium has been evolving rapidly over the last few years, and now, in addition to a few dozen plasma-derived and a dozen recombinant standard half-life clotting factor concentrates, there is a half-dozen extended half-life factor products on the market. The first non-factor therapy has also been available since 2017 for hemophilia A. And since August this year, the first 2 gene therapies have been approved, so 1 each for hemophilia A and hemophilia B. Inhibitor patients also have more options now, because in addition to activated prothrombin complex concentrate and recombinant activated factor 7, both of which were licensed decades ago, another recombinant activated factor 7 has been approved recently. It is similar to the one, it is similar to the other one, but it is not produced using a bioreactor and a cell culture like all the other recombinant clotting factors. And instead, its manufacture involves transgenic rabbits engineered to produce human factor 7 in a mammary gland and secreted into the rabbit's milk, which is collected and processed for isolation and purification of the target protein. Initially, this product was only available in the US, but this year it has also been approved in Europe. Extended half-life products have facilitated prophylaxis and improved bleeding protection by permitting fewer infusions or higher trough levels, or both. especially for hemophilia B patients, due to 4 to 6-fold extension of factor 9 half-life achieved through fusing the protein with Fc fragment of immunoglobulin G, or with albumin, or by pegylation. The same modifications do not work as well for factor 8 because its half-life also depends on von Willebrand factor. And so hemophilia A patients typically use factor 8 extended half-life concentrates twice a week instead of 3 times, as they do with the standard half-life products. While hemophilia B patients can infuse extended half-life factor 9 products once every 1 to 2 weeks. So despite these improvements, all extended half-life products are still limited by the seesaw pharmacokinetics, and patients opting for fewer infusions still spend a considerable amount of time at low factor levels. So the pursuit of better therapies has continued. The next generation of extended half-life factor 8 replacement therapy is currently in phase 3 clinical trials. This molecule has several modifications, including fusion with D'/D3 domain of von Willebrand factor, which uncouples factor 8 from the endogenous von Willebrand factor, and thus breaking the half-life ceiling imposed by VWF. These changes extend the factor 8 half-life to over 37 hours, which might permit once weekly or fewer infusions when this drug makes it to the market. This product has performed very well so far in clinical trials and will likely get licensed next year. Other novel therapies have also made great strides, and several non-factor therapies as well as gene therapy have advanced to phase 3 clinical trials. And one non-factor therapy, a bispecific antibody, has been already available since 2017. All or most of these non-factor therapies use completely different mechanisms of action, and they offer several improvements over the standard replacement therapy, such as easier subcutaneous administration, efficacy in both patients with hemophilia A and B, with or without inhibitors, less frequent infusions, and departure from the seesaw pharmacokinetics. In general, they show comparable or better efficacy to standard prophylaxis, but they do have several limitations as well, such as the risk of thrombosis. Also, they do not normalize hemostasis, and they cannot be measured using the legacy assays long established in the monitoring of replacement therapies. Emicizumab has been the first and so far the only approved non-factor replacement product for severe hemophilia. It's a bispecific humanized monoclonal antibody that mimics activated factor 8 insofar that it binds activated factor 9 and factor 10, bringing them close together and thus allowing for activation of factor 10 in the absence of factor 8. So it works in hemophilia A only. It can be infused subcutaneously once a week, once every 2 weeks, or once monthly, and maintains steady levels in the patient's system without much fluctuation. And these levels are equivalent to factor 8 level of approximately 10%. And despite the many desirable features, there is room for improvement. One important limitation is the relatively low specific activity. This means that when looking at emicizumab and factor 8 proteins, protein doses, pound for pound, you need 1,600 times more emicizumab protein than factor 8 protein to achieve the same hemostatic activity. So next generations of this technology will be aiming to improve that aspect to achieve steady levels equivalent to more than 10%. 2 such molecules are already being developed in the clinic, and we will likely see even more. Emicizumab was developed via recombination of a huge library of mouse and rat anti-factor 9A and anti-factor 10 antibodies. This process lends itself well to looking for new, interesting drug candidates because it involves both an element of chance and directed tweaks to promising molecules to best optimize their properties. 2 new bispecific antibodies are being currently evaluated in phase 2 clinical trials. They are promising lower doses and non-hemophilic range of factor 8 equivalent thrombin generation. There are several agents in clinical studies that are described as rebalancing therapies. That's because in normal hemostasis, the procoagulant factors such as factor 8 and factor 9 are in balance in a way with anticoagulant factors. These anticoagulants are physiological inhibitors of blood clotting, which keep blood clotting from clotting excessively beyond what's necessary to stop the bleeding, because otherwise excessive clotting could lead to thrombosis. So when we have a deficiency of procoagulant factors such as hemophilia, one way of looking at it is that these two components are out of balance with anticoagulant factors dominating. Now we can restore the balance by replacing the missing procoagulant factor, which is what we do in standard replacement therapies with factor 8 or factor 9 concentrate. Or we can partially neutralize or eliminate anticoagulants, which is what the rebalancing therapies do. Therapies under investigation target 3 different physiological inhibitors of coagulation using different mechanisms. One approach targets tissue factor pathway inhibitor using monoclonal antibodies. Tissue factor pathway inhibitor blocks activated factor 10 and the complex of tissue factor and activated factor 7. 4 different anti-TFPI monoclonal antibodies have entered the clinic to date. 2 are in phase 3 trials. 1 has completed phase 1 and will likely proceed to phase 2. And 1 was terminated during phase 2 due to serious thrombotic events. 1 of the phase 3 trials was put on hold also due to thrombotic events, but then resumed following protocol modifications. All of these molecules are administered subcutaneously once daily or once weekly. Another rebalancing agent under investigation called fitusiran is a fully synthetic small interfering RNA. The RNA backbone has been chemically modified to increase stability because otherwise RNA is extremely prone to degradation. And these modifications also prevent the recognition of the molecule by innate immune receptors. The RNA moiety is conjugated to a sugar called N-acetylgalactosamine, which makes the molecule able to be taken up by hepatocytes via a specific receptor where it knocks down the antithrombin transcript. As a result, the hepatocyte cannot produce antithrombin. Antithrombin primarily inactivates thrombin and activated factor 10. Fitusiran is administered once monthly under the skin. The clinical program has been put on hold twice due to thrombotic events, but now continues following dosing changes, additional concomitant medication precautions, and a more stringent monitoring of antithrombin levels. The latest addition to the group of rebalancing therapies is SERPIN-PC. This molecule is a serine protease inhibitor, or SERPIN, of activated protein C. Activated protein C breaks down activated factor 8 and factor 5. This therapy is administered once monthly under the skin and is now in phase 2 clinical trials. And finally, the much-awaited gene therapy. Historically, our community has been looking to gene therapy for the ultimate cure that will produce a sustained correction of hemophilia upon a single intervention. In the last several years, clinical studies have demonstrated that it does have the potential. And 4 different gene therapies, 2 each for hemophilia A and B, have advanced to phase 3 with the first 2 regulatory approvals granted this year. They all administer AAV vectors encoding factor 8 or factor 9, targeting the liver, in a single bolus injection in a peripheral vein. The arrival of these first 2 gene therapies at long last is a major milestone and unsurprisingly has generated a lot of enthusiasm. In fact, they do normalize factor levels in some individuals, but fail in others, or produce moderate or mild hemophilia factor levels, or super high factor levels, way above the upper limit of normal. So there is wide variability in therapeutic responses for both hemophilia A and B gene therapies, more so for hemophilia A. In addition, while factor 9 levels in hemophilia B gene therapy recipients remain stable over many years, factor 8 levels decline over time. And this drop-off has been seen across the board in all hemophilia A clinical trials, especially at the highest vector doses. We don't understand why factor VIII levels fall, and we don't fully understand the variability. And also, we don't fully understand mild liver toxicity manifesting as liver enzyme elevations, which is a common, albeit asymptomatic adverse event seen in many, sometimes in most participants of the trials, prompting immunosuppression. Immunosuppression is variably effective in managing these elevations, and we don't understand that either. So there are many unknowns about the short and long-term safety and efficacy of gene therapy. It has shown promise, it continues to show promise. It works well in some individuals, and it has brought us remarkably close to the dream of a cure for hemophilia. But we are not actually there yet, at least not for hemophilia A. And this goes to show that clinical development has far outpaced the fundamental biological understanding of gene therapy using adeno-associated viral vectors. In recognition of these many uncertainties, the first gene therapy for hemophilia A has been conditionally approved in Europe. Full approval pending more long-term safety and efficacy data and completion of additional studies. In the meantime, efforts are well afoot to improve the AAV platform, use alternative viral vectors or non-viral gene transfer approaches, but all of those are preclinical or at a very early clinical stages. So we need to wait and see what they really bring to the table. And I'll stop here. Thank you for your attention.
Thank you, Radek, for taking us through about 4 hours worth of talks in 15 minutes, very effectively. Appreciate that. Our next speaker is Catherine Hayward, who will be speaking on the diagnosis of platelet function disorders. Catherine, it's yours.
Thank you so much. It's my pleasure to be speaking on platelet function disorders, which are very challenging conditions to diagnose. And I thank you for including patients with, or issues important for patients with platelet disorders in this session. I'm going to present this with the perspective of a clinician who sees patients, head of a regional coagulation lab that diagnoses platelet disorders, and also perspectives as a researcher who appreciates that there's a lot we still need to know about these disorders. If I could have the next slide. I don't seem to have control at the moment okay. I don't have any relevant disclosures. Diagnosing platelet disorders requires consideration of the person's bleeding history and laboratory diagnostic testing that needs to include confirmation of abnormalities on follow-up samples or more specific tests. I want to start with a case, a very typical problem, 24-year-old female with a clear mucocutaneous bleeding problem, bruising history that's quite striking and goes back to childhood, prolonged bleeding from cuts that can last hours, delayed wound healing, prolonged bleeding with loss of baby teeth that lasted days but didn't get bad enough to need medical attention. A common problem for women with platelet disorders is heavy menstrual periods starting at menarche, resulting in consultations, medical therapy to reduce flow, and needs for treatment of iron deficiency anemia. This person had, apart from her menses, no other hemostatic challenges, no one else in her family with bleeding problems, generally well, drug history is negative, ISTH BAT score is consistent with a mild bleeding problem, and she's already been investigated for von Willebrand disease multiple times, has a normal platelet count, and at the time she was seen, she wasn't anemic. So this shows the results of her aggregation tests, and it really needs an expert lab to look at these. You can see there's very little aggregation and deaggregation with many of the things that we tested. She has a normal response to a few agonists. And we rely on the laboratory's maximal aggregation reference range to decide what to call normal and what to call abnormal for somebody like this. She was also tested for platelet-dense granule deficiency by electron microscopy, and this shows the typical pictures of platelets that we evaluate by the technique. We do this to get an average number of dense granules per platelet. This is one of the common bleeding problems. About 6% of patients referred to us for bleeding will turn out to have dense granule deficiency, which is getting close to the number of patients we see with newly diagnosed von Willebrand disease, but this patient doesn't have that diagnosis. She did have exome sequencing done, and no pathogenic mutations were found to explain her platelet function abnormalities, which is a very common finding with our current level of knowledge about the causes of these disorders. So, important points about platelet function disorders. The bleeding is really generally very similar to von Willebrand disease, and some types, such as dense granule deficiency, are about as prevalent as von Willebrand disease. So we really need to think about when and how to test for these conditions. These conditions can be challenging to diagnose. They can present with a low platelet count, defective platelet function, or both. So we need to look at the complete blood count data, platelet morphology on a blood film, as well as platelet function. And some have syndromic features or non-blood phenotypes that we need to think about when we're assessing the patient. And exome sequencing predominantly uncovers the cause in those where we have an obvious disorder that we're suspecting based on the clinical or laboratory phenotype. If we look at the bleeding scores of patients with platelet disorders compared to healthy controls, patients with type 1 von Willebrand disease, and we compare those with low platelet counts and inherited thrombocytopenia versus an inherited platelet function defect, there is overlap in bleeding scores, but the bleeding scores are higher in those with function defects affecting their platelets. And there's, interestingly, a higher bleeding score burden in women with platelet disorders than men. Some of that relates to sex-specific bleeding, but interestingly, women with platelet disorders have more mucocutaneous bleeding symptoms than affected males. So that, in part, explains why we see, when individuals are referred, many more women with these conditions than we see males. If we look at the causes of bleeding, thrombotic, and platelet disorders, and this was a paper published a few years ago, at that time, 91 genes were implicated in bleeding and thrombotic disorders, and more than half of those genes are mutated in disorders of platelet function and or formation, with about half of those showing a dominant inheritance. So if you're interested in seeing patients with platelet disorders, this is a very complex field to try and get a handle on the data. Of the commonly performed platelet function tests, there is no good screening test. The PFA 100 is an optional test. You can't use it to rule out a platelet function disorder. And if the test is abnormal, you have to go on to look at other tests. Aggregation tests remain our most important type of investigation for platelet function disorders. It detects both common disorders like the one I presented and rare conditions. Platelet secretion tests can be used to evaluate alpha or dense granule secretion. Electron microscopy, I've shown you an example of using that to diagnose dense granule deficiency. And we have some other tests, including flow cytometry, that's often used to evaluate for glycoprotein deficiency, but can be used as well to evaluate platelet activation and granule secretion. And in the case of Quebec platelet disorder, which has a very different bleeding history from most platelet disorders because it's a fibrinolytic defect, we go straight to genetic testing as the first investigation. That's the best strategy for that disorder, but that's an unusual example. In 2015, the ISTH made a guidance document on how to do a diagnostic workup for platelet disorders. And I'll just highlight the importance of looking at platelet number, morphology, aggregation tests, and then doing some further phenotyping to try and identify the cause of the person's bleeding disorder. That guidance document also recommended some second step investigations. Some of the proposed tests to be done are challenging to diagnostic labs to offer. This is a cartoon that we put together recently looking at the causes of platelet disorders, just to illustrate how complicated this is. And these are the currently known disorders, and a lot of what we see is not yet sorted out in terms of the genetic cause. So there can be defects from early to late stages of platelet formation and numbers. There can be defects in activation, agonist responses, adhesive events, and also defects in platelet procoagulant function. So many of the disorders get picked up by abnormalities in platelet count and aggregation tests, but there are some platelet function disorders that aren't detected by such strategies, which we need to keep in mind. There are a number of guidance documents now on how in a laboratory you should diagnose platelet disorders. And I would suggest, if you're looking to keep yourself updated on what's currently available, the ISLH website has a guidance inventory posted on its website, so you can look for new guidance documents there. It's important when we're doing testing in a laboratory that we have some idea of the correlation between what we're seeing in the lab and the patient's clinical problem. So we have done studies at our center looking at the likelihood of the patient having a bleeding disorder based on particular laboratory findings. And you can see from the odds or likelihoods ratio for different conditions based on laboratory findings that these are really quite valuable diagnostic tests. So aggregation tests done either with platelet count adjusted or native platelet-rich plasma. If the test is abnormal with 2 or more agonists, is very predictive of a bleeding problem. Same thing with dense granule deficiency by electron microscopy. The findings differ for aggregation tests done with different types of PRP. So it's very important that laboratories have a procedure-specific reference range. And although there's more variability with a few agonists with platelet count adjusted samples, when we directly compared them, these strategies for the ability to detect a platelet function disorder, the platelet count adjusted platelet-rich plasma actually proved to be superior as a strategy for picking up a platelet function disorder. In the laboratory, we consider guidance on how to interpret a patient's test based on what we find. And this summarizes the guidance that was published back in 2010 that I think is still very valid today. We are looking for patterns that suggest specific diagnosis, such as Glanzmann's or Bernard-Soulier or aspirin-like defect. But all too often, what we end up seeing when the test is abnormal is a situation like the patient I presented, where we've got abnormalities with 2 or more things that don't fall into a specific known pattern, and that suggests a platelet function disorder is present, and we go ahead and confirm this on a second test. This slide summarizes some of the patterns we see in abnormal aggregation responses in different types of platelet function disorders. And one thing that I would like to point out that is very important for labs to consider is using a strategy to compare arachidonic acid and thromboxane analog so that you can be confident you can distinguish an aspirin-like defect from some of the other important causes of platelet function disorders without comparing both. You can overdiagnose an aspirin-like defect and miss important diagnoses such as RUNX1 mutations. This summarizes aggregation findings and ATP release findings for a cohort seen at our center with platelet-dense granule deficiency confirmed by electron microscopy. So there isn't one particular finding in dense granule deficiency. You can have normal aggregation and secretion tests. Neither of those tests are good enough to screen for this disorder, and that's why we recommend, if you can do it at your center, to include testing for platelet-dense granule deficiency in your initial investigations. We also are often faced with a patient who has a low platelet count that is suspected potentially to have a platelet function disorder. So this is an example of investigating such a patient. It was an individual that I saw who had a low platelet count, as did her son. On both of her aggregation tests, she had reduced aggregation that was evident with both ristocetin and a high concentration of collagen. And that suggested a particular diagnosis to me. We did some further flow cytometry to identify that she was deficient in glycoprotein alpha 2b beta 3. And in the research lab, she was found to have an activating mutation in the platelet fibrinogen receptor that we're now working on getting confirmatory testing done in a clinical lab to provide a diagnosis to this family. So I want to end there. Platelet disorders are common, they're complicated, but very important to diagnose. And I thank my colleagues and collaborators for much of what I have learned over the years in seeing patients with these disorders. Thank you.
Thank you very much, Catherine, and appreciate your speaking about something that we don't often talk much about, but yet remain very important in the bleeding disorders community. I would like to now bring our last speaker on, Andy James, who will be speaking on women and girls with bleeding disorders. Andy?
Thank you, Glenn, and thank the organizers, too, for allowing me to speak to you about pregnancy in women with bleeding disorders. Let's see. I'm having a little trouble advancing. There we go. These are my disclosures, none of which are relevant to this talk. I'm going to start with some background about maternal bleeding in general. As most of you know, pregnancy is a hypercoagulable state, and it's important to know that women with a healthy placenta do not bleed during pregnancy, whether they have a bleeding disorder or not. And women with a bleeding disorder are less likely to have systemic bleeding when they are pregnant compared to when they are not. Nonetheless, compared to other women, women with a bleeding disorder are more likely to bleed at the time of delivery. They are not, however, more likely to have a massive life-threatening hemorrhage. Massive life-threatening hemorrhage with coagulopathy almost always evolves from obstetrical or surgical bleeding at the time of delivery. And turning to fetal and neonatal bleeding, it is very unlikely in an infant with a mild or moderate bleeding disorder to bleed at the time of childbirth. Infants with severe bleeding disorders, however, can have life or brain-threatening bleeding, i.e. intracranial hemorrhage. Because hemophilia is X-linked and an abnormal gene in only one single X chromosome can result in a severely affected male infant. Other severe bleeding disorders are almost exclusively autosomal recessive, require two abnormal genes, are extremely rare, and rarely anticipated. If we look at what the prevalence is of bleeding disorders among females, we can look to surveillance data from the United States Hemophilia Treatment Centers from 2012 to 2021. This is actually the proportion of different bleeding disorders among women who are registered there. 62% had von Willebrand disease, 7% were carriers of hemophilia, 11% had various other clotting factor deficiencies, 19% had platelet disorders, 2% had connective tissue disorders or disorders of fibrinolysis. And as I already stated, and as you already know, pregnancy is a hypercoagulable state with increased levels of von Willebrand factor, factor VIII, fibrinogen, some other clotting factors, no significant increases in factor IX, interestingly, decreased protein S, a natural anticoagulant, decreased fibrinolytic activity, decreased platelet number, but increased mean platelet volume and increased platelet reactivity. These are data from a multi-center prospective study we did looking at von Willebrand and factor VIII levels postpartum in unaffected women and women with von Willebrand disease. And we stratified it according to whether their levels were greater than 50% going into delivery or less than 50%. On these three graphs, in gold, you can see the factor levels for the unaffected controls. You can see how they rise very high around the time of delivery and then fall so that they're approximately baseline by 2 to 3 weeks postpartum. In blue, you can see women who started out at the time of delivery with levels greater than 50%, how they rose and how they returned to baseline at 2 to 3 weeks postpartum, but were at all points lower than the women who were unaffected. And in red, you can see women who had von Willebrand factor levels less than 50% were treated per protocol in this study, but none, despite the fact they were treated, did not achieve the levels that women without von Willebrand disease did. On the far left, that graph is von Willebrand factor activity. In the middle is von Willebrand factor antigen, and on the far right is factor VIII activity. What kind of bleeding do women with von Willebrand disease experience around the time of delivery? We have the most data on it compared to other bleeding disorders. Well, they are about a 10-fold increased likelihood of having bleeding during pregnancy itself, an increased risk of postpartum hemorrhage, a 3-fold increased risk of severe postpartum hemorrhage, and a 3-fold increased risk of forming a perineal hematoma. These are data from the same prospective study I was alluding to, and these are modified pictorial blood assessment chart scores over the 6 weeks postpartum. And the bars in blue are scores from women without von Willebrand disease. In green, women with von Willebrand disease who had levels starting out greater than 50%. And in red, those who had levels less than 50% and were treated. And you can see that the levels are similar, or the PAD scores, excuse me, are similar for the first 2 weeks postpartum, but then there's divergence. This may have to do with the fact that prophylactic treatment was discontinued at that time. And you can see that the red bars are significantly higher than the blue or green bars. Also, the estimated blood loss at delivery among the women who had levels less than 50% starting out at the time of delivery were 40% higher than their unaffected counterparts, and their nadir hematocrits were 20% lower. Reassuringly, in women who had levels greater than 15%, per protocol, no treatment was administered, but they also had no increased risk of postpartum hemorrhage. Now turning to hemophilia. For every 100 males with hemophilia, there are 156 carriers. These are the ISTH categories of hemophilia carrier. And you may not be able to read all the print here, but let me describe to you that the categories are stratified first by factor 8 or factor 9 plasma levels. In those women with factor levels less than 40%, they are described as having hemophilia, and their severities are classified the same as men with hemophilia. On the right is the stratification by level of factor greater than 40%, and these women are classified according to their bleeding phenotype. If they have a bleeding phenotype, they're considered symptomatic carriers, and if not, they are considered asymptomatic carriers. And then I would like to make a few points that are relevant to any bleeding disorder, and that is about maternal hemorrhage prevention around the time of delivery. Almost all bleeding at delivery is due to obstetrical or surgical reasons and not a pre-existing coagulation disorder. And that is important, one, for our understanding and for management. Obstetrical and surgical bleeding should be managed aggressively and not blamed on an underlying coagulation disorder. IV tranexamic acid can be safely used immediately after delivery, 1 gram, and repeated in 30 minutes. Oral tranexamic acid, 1 gram every 8 hours, can be used postpartum. And non-steroidal anti-inflammatory drugs, which are given freely to women for postpartum pain, should be avoided. And then a few points specifically about von Willebrand disease and hemophilia. As implied from earlier slides, factor levels less than 50% after 36 weeks are associated with increased bleeding at delivery. There are no randomized trials to guide treatment. Recommendations, therefore, are based on observational studies and expert opinion. Treatment is recommended for women with factor levels less than 50%. The type of treatment and the duration is not uniform, but there is general consensus that it should be continued for at least 3 days after a vaginal delivery and at least 5 days after a cesarean delivery. And our work would show that it probably needs to be continued longer. Plasma-derived or recombinant products are recommended over cryoprecipitate or plasma when they are available. And regional anesthesia is considered safe if factor levels are greater than 50%. And in almost all cases of von Willebrand disease, a severely affected infant is not anticipated. And when a severely affected infant is not anticipated in a woman with a bleeding disorder, the baby still may be at risk of a mild or moderate bleeding disorder. So we should avoid fetal scalpel electrodes, avoid operative vaginal delivery, and that means forceps or vacuum assistance. And circumcision should be postponed in male infants until they are evaluated after delivery. And when I say operative vaginal delivery, what do I mean? I mean the use of a vacuum device to assist delivery or metal forceps to assist delivery. Intracranial hemorrhage, however, is associated with mode of delivery. These are the results of a systematic review performed by Davies and Kadir and published in Hemophilia in 2016. And they found in affected male infants, the odds of intracranial hemorrhage with vaginal delivery were 9-fold. The rate of intracranial hemorrhage with vaginal delivery was 3.1% and with cesarean delivery 0.4%. And this is all cesarean deliveries. This doesn't include cesarean deliveries before labor, in which case the risk may be even lower, since traumatic labor followed by cesarean can still increase the risk. These are newer data, and they're from a European registry. There were large number of participants. And you can see here that the intracranial hemorrhage rate with planned vaginal delivery was 2.5%. And that includes spontaneous vaginal delivery and assisted or operative vaginal delivery, compared with cesarean delivery before labor, where the rate was 1.6%. Lower than the planned vaginal delivery rate and the cesarean after labor. So significantly lower. But what is particularly of concern is in the footnote, 4% of the deliveries, the vaginal deliveries, or excuse me, 4% of the deliveries of obligate or possible carriers were conducted by forceps or operative vaginal delivery. Now, why would that be if these were known carriers and a potentially affected male infant? Well, there is a point of no return in the maternal pelvis. The baby's head can descend so far. When there is fetal distress, there may be only one option, and that is by operative vaginal delivery to get the baby out. So the only way to avoid an operative vaginal delivery is to plan for a cesarean delivery before labor. Now, this might be helped by our being able to identify the fetus at risk in advance. Specific genetic testing is available to women who have been genotyped through either pre-implantation genetic testing of embryos that requires in vitro fertilization, prenatal genetic testing by chorionic villus sampling or amniocentesis, or what is popular at our institution, prenatal genetic testing by amniocentesis in the 3rd trimester for delivery planning, where there is then no risk of miscarriage. Also, the fetus at risk can be identified partly by determining the sex of the fetus, and the now can be done anytime during pregnancy with cell-free fetal DNA testing after 10 weeks of gestation, prenatally by genetic testing by chorionic villus sampling or amniocentesis, or ultrasound imaging. And ultrasound imaging is available almost everywhere in the world. So when a severely affected male is anticipated, either possible or prenatally diagnosed, I recommend cesarean delivery. This is a summary of types and severities and treatments of other factor deficiencies that are probably the next most common bleeding disorders after von Willebrand disease, hemophilia carriership, and platelet disorders. And that includes factor 7 deficiency, factor 11 deficiency, and fibrinogen. And what I would like to point out on this slide, which maybe you can review later, is that women with fibrinogen deficiency are not only at risk for maternal bleeding, but because of fibrinogen's role in normal normal placental adherence, they are at risk for miscarriage, placental abruption, and abruption in labor, and as well as at risk for postpartum hemorrhage. As you saw from one of the earlier slides, platelet disorders are more common even than hemophilia carriership, and depending on how they're classified, are as common and even maybe more common than von Willebrand disease. Severe platelet disorders are rare, and they require all the treatment listed above, but perhaps platelet transfusions and recombinant factor 7A. What I'd like to point out about Glanzmann's thrombocythemia, though, is that the fetus may be at risk of thrombocytopenia, not just from a potentially inherited disorder, but from maternal alloantibodies that target fetal antigens on platelets that the mother doesn't have. So my final points are that a mildly affected mother can be managed with routine care and delivered locally with the hemorrhage prevention measures I discussed, but a moderately or severely affected mother, besides hemorrhage prevention, should have hemostatic treatment, multidisciplinary care, and delivery in a hemostasis center. If a woman has a baby who's mildly affected and she is also only mildly affected, then hemorrhage prevention measures there include avoidance of invasive procedures in the fetus, but the baby can receive routine care and delivery locally. However, an anticipated moderately or severely affected infant should be delivered atraumatically, ideally cesarean before labor. There should be anticipation of need for factor. Baby can anticipate multidisciplinary care and deliver in a hemostasis center. So thank you very much for allowing me to speak. And now I think we can entertain questions.
All right. Well, thank you very much, Andy, for that tour de force on pregnancy in women with bleeding disorders and how to manage the babies that are at risk. We have some questions. Catherine, thank you for your efficiency in answering some. I would refer our audience to the answered Q&A for some of Catherine's responses. But let me start off, Andy. We've gotten a whole series of questions for you, and maybe the first one is important for our audience. There are going to be countries that are in attendance today where they don't have any sophisticated testing available to do any sort of prenatal diagnosis. What might you suggest as a standard operating procedure if it's known that the baby may be at risk for a bleeding disorder because of a family history with brothers, for instance, who may have had a bleeding disorder? How should that pregnancy be considered?
In this case, we don't expect that the mother will bleed or that the baby will be at risk in utero until the time of delivery. Everywhere where maternity care is provided, almost everywhere, we can use ultrasound to sort out whether there is a male or a female fetus. If there is a male fetus, and my recommendation is cesarean delivery, but if this woman has had easy vaginal deliveries and we have reassurance from ultrasound that this baby is normally proportioned, etc., then perhaps we could proceed with a vaginal delivery. However, when in doubt, everywhere that provides obstetric care has the capacity to deliver by cesarean. It's brain protective, and it's a lot easier to deliver baby by cesarean than try to treat an intracranial hemorrhage afterwards. One of the comments I get is, well, why would we want to subject a woman who has a potential bleeding disorder herself to a cesarean? Well, in fact, the risks of bleeding, when we combine the risks of bleeding with unplanned cesarean from a failed normal labor, and we combine all those risks with spontaneous delivery, they actually offset the risks of bleeding from a planned cesarean. So in terms of maternal risk, they're comparable.
Okay, thank you. Another question is, it's about mild bleeding disorders, including platelet function abnormalities, but often the diagnosis of the newborn is difficult. What's your general recommendation on circumcision in newborns? Delaying it until one can make a diagnosis, or?
Yes. Yes, this is not essential for the boy's life. Having been in the field for many years, that's not always apparent to the parents. But in general, it is better to be safe than have the baby bleed.
Okay.
And that is the most common source of bleeding in infants, among infants who are enrolled in our Centers for Disease Control and Prevention registry.
Well, and I would say in our humanitarian aid program, circumcision occurs at different times in different cultures. And so if it occurs a little bit later, we do make sure that product is available to use during the circumcision so that there's not a risk of excess bleeding. Here's a technical question for you that I don't have any idea what the answer is. Do you recommend delayed cord clamping after delivery to avoid anemia in infants with a bleeding disorder?
So, there is research to support that, and it is our practice at our institution, unless the baby is critically ill and we don't have time to wait. So.
Okay. And Catherine, you commented a little bit on some answers. So in lower resource countries where one may suspect that there is a platelet defect, but may not have the ability to analyze it, or may need to work with a distant laboratory where samples would need to be sent, what suggestions might you have for being able to get accurate diagnoses if samples need to be sent somewhere?
So that is difficult because a lot of diagnostic strategies rely on rapid testing of a freshly collected sample to evaluate platelet function. But Andreas Granacher's group has described using dried blood films to do immunostaining to diagnose certain conditions. I think, I have traveled to resource-poor countries where consanguinity is a commonly accepted cultural practice, and I find often in those countries they do perform tests like aggregation tests and diagnose rare platelet disorders that are recessively inherited far more commonly than we do. So I think many under-resourced countries do offer testing for some platelet disorders. They may not do testing for dense granule deficiency. So that's something to keep in mind. That's a mild bleeding disorder that you would treat very similar to mild von Willebrand disease. So drug therapy there works for most patients, but I think many patients are unhappy with not knowing the cause of their bleeding if you can't do testing to answer what might be or is not the cause of their bleeding problem.
Okay, thank you. We've got time for two more questions. One for Radek, one for Andy. Radek, with all of the various products that are commercially available in many different geographies, as well as those that you described that are coming and may be licensed over these next couple of years, can you make a comment on how patients should be thinking about what product to take and what sort of constraints there might be depending upon where they live?
Sure. I think as much as in the past, it's still true today that safety is key. A lot of those products that I have described, most of them have demonstrated safety. I mean, clotting factor concentrates, both plasma-derived and recombinant, have demonstrated safety for many years. We really know very well how they work. We clearly understand very well the mechanism of action. There were really no known unknowns here. With a number of novel therapies, especially gene therapies, there is a big number of unknowns, depending on the geography, the risk-benefit ratio may be a little different in terms of gene therapies. Despite of the many unknowns, both gene therapy for hemophilia A and B demonstrated that they can keep the vast majority of individuals off prophylaxis or standard treatment and almost bleed free. So that'll be a important consideration depending on where you live and what access to what kind of treatment you have in your geography.
Okay, thank you. And Andy, this question is maybe a little bit off from pregnancy, but perhaps you could tackle it. Women with mild hemophilia, it's been reported that they have perhaps a bit more of a severe phenotype than men with mild hemophilia who have the same level of factor VIII or factor IX. Could you comment a little bit about possible reasons for maybe more severe phenotype at the same factor level in women?
So how I see it and explain it, keep in mind I'm an obstetrician gynecologist, women have bleeding challenges that men do not. They have miscarriage, childbirth, menstruation, and even Eric von Willebrand in his original paper about von Willebrand disease said that women were twice as likely to have the condition as men, even though we know the genetics are similar. So we think that women are disproportionately affected because of the bleeding challenges, menstruation, childbirth, miscarriage.
Okay. Simple answer to a complex question. Thank you. With that, I think we do need to end. I very much appreciate all of the panelists and our speakers for a very engaging 2 hours where we covered the gamut of bleeding disorders throughout the world. So thank you all. Thank you to our audience as well for your participation and for all of your good questions. Until next year, have a happy holiday, Merry Christmas, Happy Hanukkah.